Okay, so now the needle entry point in the transforaminal endoscopy is a very specific mathematical calculation. And this mathematical calculation, if you follow, you will never fail and you will never end up with the complication. So you just have to understand the methodology, then you will be able to proceed. So like you see, what we always say, if you have 2 points, how many lines you can make?
Two lines. 2 points. One line.
Joining, yeah, only one line.
One line.
And if you have 1 point,
Many lines.
infinite
Infinite line.
going through. Okay, so like 2 points, so like 1 point is your end point, which is the disc herniation, which is fixed in that particular patient. So you have only one entry point, which will be correct and which will be perfect. The other will be okay, like that. So you have to choose a very specific entry point, and that entry point is going to give you your perfect trajectory, where this point and your point you will align, because all of your instruments, the sleeve, dilator, they are straight. It will just reach there. Okay. So now how will we do the calculation? So normally, if you see, suppose this is the skin of a patient. So in a normal average adult person, if you take the distance from here to the center of the disc, this distance is around 7.5 centimeters. So like this has been studied. Like maybe in Indonesia, maybe a little less, or in Africa it may be a little more, but average is this. So this distance, I take the same distance here, and if I make this triangle, what will be the angle?
45.
Okay. So means if you take the distance from this, now forget about 7.5. So like this is, suppose this is A. So if you take the distance of A from the center of the disc to the skin in the lateral view, same distance you take, with a 45-degree angle, you are going to able to go to the center of the disc. But our target is not the center of the disc. So now for the sake of comfort, what we are doing? We are doing anterior part of the disc. So this anterior part of the disc is around 1.5 to 2 centimeter. Okay. So I'm just giving you, you don't take this number, that will differ according to the patient belt and everything. So now this is B. Okay. So now this is A. So now it's the same if I extend the B. Yeah. So again, if I make the same line, okay. So this, again, this angle will be
45. 45.
So if this A plus B, so in a lateral view, you take this distance.
Yeah.
So you put the marker, and then you put the guide wire or something, and you put the marker. Okay. So this distance is A plus B. You take the same distance on the disc inclination line. I'll tell you what is the disc inclination line. Because the discs are inclined. Okay. So that disc inclination line, this A plus B distance, take the angle less than 45, because our target is posterior annulus. So if you take this angle, you will be able to reach to the posterior part of the annulus. And then, so what we do, we start from here, we try to hit the facet, and then we try to go below the facet. You try to be very close to the facet, so you will not injure any nerve, because that area is very fixed. And since we have the dilator, which is a conical shape, is a bullet shape, so it's not going to, even if the nerve is in between, it is going to retract the nerve. And this way, you can go to the disc. So this area, when you reach to the subannular area, so you go inside the disc. So inside the disc is avascular, neuronal. So you are not going to have the bleeding, you are not going to have the nerve injury. So you are perfectly fine, and then you just have to do the removal of the fragment. So basically, when you go inside the disc, so it's called the inside-out technique. When you remain in the epidural space and you just remove the tip of the herniation, it's outside injection. But whatever we do, inside out technique is having a certain more advantage, because you see whenever, like this is annulus and this is a disc. So whenever the disc goes out, it goes out with the pressure. So it just breaks the annulus. So there are 17 to 20 layers of the annulus. So it breaks all the layer and then the herniation goes out of it. So this is we call the neck of herniation, which is very tight. It is holding the fragment. So even this fragment, if there is this is annular tear, and even if this fragment has gone out like this, so this neck is very tight, and this is the reason that because of the this fragment contains the cytokines, what we like as A2, which is a very highly chemical irritant. So it produces a mechanical pressure where it doesn't let the annulus to seal, and it produces a constant inflammation. So this constant inflammation is the reason for the constant pain. And that's why these are the patients, they have the symptoms for years together. They will never be. If you have the extruded portion going to the canal, there are chances that it will dissolve by the phagocytic activity. But the fragment which stays inside the space, annular area, it will never absorb, because here is an avascular structure. So the fragment will always remain there. So what exactly we do in the transforaminal endoscopy? So we go inside the disc and then we visualize the annulus and we cut the annulus to make this one more bigger. So actually we are widening the neck of the herniation. So the herniation will become free. So then you can hold any part of the herniation, the whole herniation will come out. So you don't need to go and catch the herniation. Even the herniation is inside the canal. But if you have made this neck of the herniation wide, it will easily come out and your job is finished. So like there is no need to go directly to the canal, because you have the option, you can directly do this. So that is the principle of transforaminal endoscopy. You go with a certain degree of angle. What are the advantages? Once you go through the annulus, the annulus will act as an anchor. It will hold your cannulus. So the cannula is fixed. The second is facet. So facet you can use as a lever. So like suppose if I am going like this, I can use the facet as a lever to see more dorsally also. So this is a big advantage as compared to outside in technique, where you directly go to the epidural space and then there is a hell of bleeding because of the fragment material is there, because of there is a lot of inflammation, and then you have the nerves, and your visualization starts after you putting the sleeve and dilator. So like suppose if you have done the damage, you have already done the damage, now you are saying, oh my god, what is this? This looks like Dula, huh? Or you see the gush of blood is coming here. So that's why like usually initially when you start doing the transforaminal endoscopy, it's always better to go with the inside out technique, where you go inside the disc, and the biggest advantage of the inside out technique is you don't all see what we do in the transforaminal endoscopy inside out technique. We remove the herniation and we also remove the free fragment of the disc which are likely to be herniated in future. So all possible free fragment also you have to remove. Otherwise you see, like you will hear from everyone, a transforaminal endoscopy very high recurrence. But my friend, you have not removed the free fragment, which is already there. So you have to remove the herniation and you have to remove the free fragment also. Second thing is, like see, I give you the example. If I have a knife, if I put the knife here, will it penetrate the skin? I'll just touch with the knife. When it will penetrate?
Forces.
If I put the pressure. Okay. The same thing is with the herniation. The herniation which is there inside the canal, pressing the nerve, it cannot produce the pressure symptoms. It's a back pressure. Some support. I'm pushing from behind. So this back support is from this part of the wrist. So even when you remove with the inside out technique, when you go to the disc, you are able to remove the back pressure also. So suppose by chance sometime your small fragment remains inside the canal, So that small piece of the fragment on the section of the nerve it will never produce a major motor symptoms. So it's a back pressure. Relieving the back pressure is the most important thing. Okay. So now this is very clear.
Yeah. Okay.
Yes.
So now when you do the discectomy, so like very simple. First you have to draw the central line. So when you draw the central line, you know where is your center. Then you draw the actual disc line. Okay. And the third line is a disc inclination line, which is the line of the disc orientation. Like you see, the L34 disc will be like this. L45 will be like this. L5 will be more like this because our lumbar spine has a lordosis. So even the 2-3 will be more like this and 1-2 will be more like this. So like the needle entry will be exactly similar. The actual disc line and inclination line at 3-4 level, it will be little above, little more above for L45 and L5S1. Okay, so and for the L23 and L5S1 it will be like this. Okay, so like you see from one point, this is L34. So like this is just more of a theoretical, but you always have to remember that the point of entry will be above for L5S1. It will be little above for L45. It will be little at the same side, 3-4. It will be below for 2-3. It will be below for 1-2. Okay, because of the disc lordosis. So the discs are like this. This is L1, L5S1, 4-5, 2-3, 3-4. So this is a rough idea. Like it has a change, but majority of the patient you have to see this. So you have this line. So what you do? So now you draw a disc inclination line, and on the disc inclination line, whatever the distance you get A plus B from the patient's marking, the same distance you put here. Okay, sorry, you put it here. So then this distance, what you measure, A plus B, you take the same distance. Then on the your entry point will be on the disc inclination line. Okay, and when you see the AP view, you see this is a pedicle. So the needle at the medial pedicular line, and in the lateral view, it has to be the posterior vertebral line.
Posterior
You
pedicular.
follow this principle, my friend, you will never fail. Because this is the most safe way. This angle is the most safe angle. Because for the L1, L1, L3, L4, upper 1, 2, 3 disc, the facets are more medial. So your entry point will be more medial because the facets are within the vertebral body or maybe quite inside the vertebral body. So actually we are going flush to the facet. So even the same distance, if you take for the L5S1, if you take for the L12 or L23, you will directly go to the pinna. Okay. So this facet orientation is very important. Then the dural sleeve, so the dural sleeve are quite wide in the lower part, it's more narrow in the upper part. So orientation of the nerve root, they are more vertical in the upper part, more horizontal in the lower part. So this all the anatomical aspect we should be aware. But again, I tell you, very simple thing. If your patient is awake, if you are touching the nerve, patient will tell you. So you don't have to worry about the anomalies or something. You keep your patient awake. Any doubt, tell them, move your leg, my friend. Then if they are moving the leg, no problem. So that is your safety. Again, the awake patient is your best neurological monitor. If you have the awake patient, you don't worry about anything. So you put the needle. So again, when you put the needle, so before this, I say in the AP view. So like needle entry, we start in the AP view. So we go to the facet. You don't cross more than lateral margin of the facet, AP view, and it should be less than 10 to 11 centimeters. Okay. So if you are like this and if you keep on going, if you are going 11 centimeters, then if you still not touch the bone, you stop it. If you are not correct, you take the lateral and you make the adjustment. Similar way, So you should be able. The first step is to visualize the facet. So the facet in AP view, you should at the lateral border of the facet, and in the lateral view, you should be on the posterior part of the facet. So that is the first step. So like I'm touching here. So like this is AP view, but if you see on the lateral view, you see okay, you are in the facet. You are not into the foramen, you are not into the canal. So like that way you make sure that you are not anterior. So the AP view is for the medial direction and the lateral view is for the depth. So these two correlation, always one picture is not like if you show me that picture, so the doctor tell me what is that, I say I don't know. Because if you put the needle on the above and take the AP view, it's the same. Even if I put the needle in the stomach, it will be the same. There is no, unless you take the lateral view, so you know, oh my god, this is inside and this is outside. So two picture, AP and lateral has a value, one single picture doesn't have any value. Because the lateral view is going to give you the depth and the AP view is going to give you the medial direction. So first, you touch the facet. So within the lateral part of the facet, when you see on the X-ray, you should be touching the bone. In the lateral view, you should be on the posterior to the facet. Then what you do, you just take out little and then go inside. So you go inside. Now you are going to the foramen. So you see, okay, I'm going fully. Then you have a annulus. So this annulus. So the second is a annulus. So this is a pedicle. So this is the middle part of the middle pedicular line. This middle pedicular line should be correspond to the posterior vertebral line. Okay, this is the lateral view. So don't proceed if you don't have this picture. Maximum we can accept is a middle pedicular line.
Yes.
Okay, but otherwise don't proceed. It will have the disaster. So this calculation, this everything, like you see, like suppose if you have this but when your facet is more medial, so if you go with the even the 8 centimeter direction for the L12, if you get the L12, but if you don't get this 2, then you have to go more medially. Because otherwise you just don't blindly follow this. This is a rough estimate which is true for most of the time, especially for the L4, L5. But because the facet orientation is different in the upper lumbar spine, so you have to have the different angle. So this is second and the third. So now you are very sure you are in the middle pedicular line, you are in the posterior vertebral line, and third is in AP view. So again, so I make another line. So in the lateral view, you should be in the posterior one side. So this is 1, this is 2. The needle should be at the posterior one side. So even any part of the posterior one side is okay. And in the AP view, it should be at the midline, near to the spinous process. So it means you are more posterior, you are more flat, and this will help you at your subannular area. So this is the annular, so your subannular. So you are exactly at the area where you have the herniation has come out. So when you go to this area, then you will see, oh wow, this is this will be mostly empty area because the disc from there has come out. So then you just do the decompression and then you come out, so you become half and half. So you see the half of the annulus and half of the epidural space, and then you start working on the annulus. Do a good annuloptomy, under vision. Once you do the good annuloptomy, it will give you the way and it will make the herniation more free. And then you put your grasper. Small grasper is better because you do everything under visualization. Some little angle grasper are more better because it will align with the axis of the endoscope. So this is, whatever you are seeing at a 30-degree angle. So what you see, grab it and just come out. So this will make your life very easy. Okay. So then you will not do any mistake, and then once you, then at the end point, once you remove the herniation, you will see the free flowing, the free movement of the epidural space. And like even you can put the hook and you can put the hook from the annular tear, so you will be able to see the hook is going up to the annular tear. So it means now the space is free. And even if you more come out, you will be able to see the pulsating nerve root also. or you may see the pulsating nerve root along with the fed. So this pulsation, free pulsation is an indication now the
point.
compression on the nerve is finished. Sometime, like most of the time, if you do it nicely, you have done enough, it takes 10-15 minutes. So it's like a epidural injection. Sometimes it will take it more time. But once you are very clear, you are done. And this is something like the most advanced technology. Even the interlaminar has a very big learning curve. You need a very good control. You need something. There is still some more advanced videos coming up. But discectomy with the transforaminal, and since this is done through the natural orifice, so you are not cutting anything. So like here we are drilling everything. We are removing the phlegm. So like even we don't know exactly that what will be the consequences of the removing the phlegm in terms of the additions or something. It will come after 5-10 years. We don't know now. So, but this transforaminal is one of the best technique because all the muscles you are dilating. We don't even take the stitch also. This is a stitch lane also, and the local anesthesia also. And the patient will come back, a lot of complaint, and they will go back. Even half an hour, 1 hour, you can make the patient stand and make the patient walk.
The sleeve one inside, you will never moving and come out because it's already top there. The sleeve, once you have already entered the space, the foramen, inside, it will never come out. It will stay there.
No. Sleeve will always you see once you land here. So you do all this decompression, whatever the free fragment, like your dog like this, okay? So you remove, then you take out sleeve. So you take out the sleeve till you are half in, half out. So half in, half out means you see the half annulus and the half epidurus. So this is half in, half out is the best place where you can see. Okay, so I have always have a habit like I use instrument like this. And then
Kelihatan epidural separuh. Oh, waktu kita
more effective.
masuk ke disknya.
The moment you
Kalau masuk ke situ itu kelihatannya kan dari kan agak ke tengah itu kelihatan kelihatan spinal kanal. Kalau ini mah kelihatannya kan langsung dis, kan kita bilang dis. Ini center kayak
unless we are not able to discriminate.
Iya, kelihatan ini.
At the end of the endoscopy, even we are using the plug. So we take the patient's blood, centrifuge it for 3000 RPM for 10 minutes, and we keep it for 10 minutes. So 20 minutes, when you get it, it's a kind of a plug. You can hold it with a forceps, and that we put it inside. So yeah, so it's either we call it the Devon plug. So my teachers of anatomy and Dr. Bone, they have invented this. And this is a very powerful anti-inflammatory. It has a platelet, it has a growth factor. So like it will take care about the small oozing. Even since it's having the growth factor, so it will help the annulus heal also. And maybe like by chance if you have done some mistake and minor dural injury or something, or dural leak, it will see because it is having the regenerating possibility.
It's like 5 week test.
Yes. So like you can you take the 15 ml of blood, it will give you this much level. So you hold it and then you put it through the sleeve. Okay. So like see our philosophy is for any kind of disconnection, central, up, down, migrated, extruded, we can do with the transforaminal because it's the most safe way. And stenosis, especially the tight stenosis, the central and the lateral canal and the foraminal stenosis, we do it with the interlaminar technique. So currently we are working on the decompressing the foramen and the lateral canal also by transforaminal route. So there we build the facet and then we remove the phlegm also from that respective area. So the advantage of this is that it's very safe. Otherwise, if you don't have the good control, the number of complications like dural tear or nerve injury or bleeding, it's something like, so it is a big learning curve. For transforaminal, so like what you can do is you can start putting the needle. So you do the same thing, put the needle and then you, instead of doing the epidural transforaminal injection, you do the injection in the disc. So if you do the injection to the disc, it will take the same path of inflammation. So like once you put the medicine inside the disc, so it will feel inside the disc. Then it will go to the annular tail. So that like inflammation is go through the same annular tail. Then it will go to the PLL. Then it will go to the epidural space and to the nerve root. So this will take care about the same path of inflammation. If you just do the root block, it will just take care about the root and the epidural. But here, so this, the patient, they are having the back pain, they will also go over with this intradiscal injection. And the most important is it will wash out all the cytokines. So once you push, let's say like what I do, I take around 10 ml of solution, maybe 40 or 80 milligram of solution of transforaminal or methylprednisolone. Then I dilute it. I mix it with the sensory dose of the local anesthetic also. And then I keep on pushing it. So normally this doesn't take more than 2.5 to 3 ml of the medicine. But if you have the annular tail, it will keep on leaking. So since I have used the local anesthesia solution, so immediately you use the 0.5% lignocaine. So the lignocaine is a very fast acting. So even like I inject half of the medicine, then I will ask the patient, move your leg and tell me how is your leg. Oh, pain is reduced. Even I ask, what about the opposite side? If you say, no, opposite side is also okay. Then I don't have to do the opposite side injection. One disc injection will take care about the disc and this side and this side also. So once you use the local anesthetic, you know that both of the sides is you need to repeat it again or not.
You do it at the end or
No.
as a procedure?
It's a pain management procedure.
Pain management.
When I am not doing the discectomy, when I see the patient is having the only chemical inflammation. Like you see, very clearly you divide your patient into the two categories. One of the patients, they have a chemical irritation. This chemical irritation is because of the chemical inflammation, because of the inflammatory mediators, especially the proteoglycan A2. The content of proteoglycan A2 is 10,000 times more in the disc as compared to the blood. It is a very severe, highly inflammatory material. So what produces when this leaks out? It leaks out with the proteoglycan A2. It produces a severe inflammatory reaction that patient will have the pain. They have not like suffer the rest of their life. So they remember. So this is because of the inflammation. So the more pain is because of the more inflammation. It means there are more chances the patient will do better with the injection. So the indication for the surgery, decompression, is only for the ongoing neurological weakness.
Weakness.
If the patient is having more pain, there are very good chances they will do very well with your disc injection or root block. And one very important thing, like even the assessment of those patients. When you have the patient, when you say, move your leg, no, pain is so much, I cannot. Oh my God, this is a motor weakness. Because patient is not letting you to do because of the severe pain. So you stop that pain and then you assess. So then the patient says, yeah, I'm okay. So we call it a pain-induced inhibition. So motor examination. So that way also that was a simple patient for the injection. And now you believe, oh, this patient is having motor weakness. So it's better you like you say we do have some options also, like we do the distal block, we call it memory block. So if you block the nerve, like the sural nerve, the 2 centimeter below and lateral to the calcaneum, if you inject there, it immediately reduces all the pain related to the nerve, because these nerves are the single pseudomonopolar axons. So if you block the nerve distally or proximally, it has the same effect. And the most funny thing is if I produce the high concentration of the local anesthetic here, it will produce the motor effect for the whole. But even if I produce the high dose of the local anesthetic distally, it produces the motor effect only distally only. So that is a very good advantage to us. If you block the nerve distally, patient will have only the relief of the sensory symptom. The motor block will only do this part of the foot. So like we do for the sural nerve, so for
Boxer.
sural nerve.
Sure.
Yeah, so here, so what you do is just palpate. If you palpate and if the nerve is tender, it means there is an ongoing inflammation. Like you see, if you touch the ulnar nerve, you touch the ulnar nerve here, what will happen? You will feel tingling.
Tingling.
So the pain is only possible when there is inflammation. In the body, there is no other mechanism except inflammation and distension will produce pain. Appendicitis, tonsillitis, all itis is an inflammatory condition. So even when the disc is having the pain, this is more because of the inflammation. And till now, this inflammation was not known. Like every patient goes for the surgery whenever you see the disc herniation, and your all radiological investigation doesn't tell you what is the how much is the inflammation. So like you see, we always correlate how is your pain. MRI doesn't look so bad, there is too much. So this inflammatory component, that is what we are missing. Yeah. So this is a very important. So like you divide your patient into the two categories. This is chemical inflammation and
It is a mechanical.
mechanical. It is a mechanical, ongoing.
Yeah.
There are good chances decompression. Ongoing. Not now.
Jangan dokter
Yeah,
Siraj.
if you are very big, huge
HP-nya
disc,
dia.
you go. But even the best of the big disc also can resolve by its own. The body has a very good protective mechanism. So this one group of patients, chemical inflammation, do the injection procedures, pressure, and the third patient, claudication. So for the claudication, it's better to do the posterior decompression because claudication is more related to stenosis and it's more related to the vascular component. Because you see, this stenosis is having two components. One is a fixed component, canal is within the nerve, and one is the vascular space. So this vascular space, because of the gravity, the blood flows down. When you walk, blood flows down. So that gives you more mechanical pressure, and this gives you the symptom to the patient. You see, otherwise those patients, they are fine while sitting or while sleeping. They don't have any problem. The only problem is when I stand or when I walk. So this is the vascular congestion is the main mechanism for the patient's claudication. So when you do the lateral canal decompression, so with the PSLD, interlaminar decompression, you can take out the lateral canal like what you see here. Okay, there was a big amount of the phlegm. Even this patient may not have the very tight canal, but still this vascular component is the reason. And once you remove this fixed component by removing the phlegm, drilling the bone, make the space for the nerve and the dura bigger, so they will be able to have the more pulsatility, and the vessels also will have the improved venous return, so they will not go into the congestion. Because you see, this vascular component, the vessels are placed here, so the blood is not flowing. So this part of the vein become more dilated. It's like a intestinal obstruction. You have obstruction here. The part which is proximal to the obstruction will get dilated. The same thing happens in congestion. So three category of patient. One is for the injection procedure, one is for the transforaminal endoscopy, and one is for the decompression. And the good thing about the even posterior decompression is you can even select even the stable recesses, even very high degenerative scoliosis or something, because you are not removing the posterior structure too much. If you need a stabilization, and usually those oldies, they already have all these small issues, and doing the open decompression, cutting the screw, that is going to definitely work the issue. And with a very standard operative technique of open decompression, microdiscectomy, tubular, if you don't remove the facet, you are not able to decompress the lateral canal and the foramen effectively. So that's why they always have the symptoms. Unless you put the cage, and the big size of the cage, it will widen the foramen, so it will give the more space. Otherwise, just posterior decompression, you will see it always fails. The patients are never happy. They say, yeah, I was able to walk for 10 steps. Now I'm walking 15 steps. But still, like after 15 steps, this happens. So the pathology of spinal canal lies into the lateral canal and the foraminal. Okay. So you see, your procedure will come later once you have to have the diagnosis. Once you are very sure about the diagnosis, then only you will plan for the procedure. And by learning all these things, you will have like 95% of the patient in your pocket. And like you see, your friends will advise about the open surgery or decompression and general anesthesia and everything. And now you advise this, the patient will definitely come to you. So this can become a game changer, life changer in your practice to learn this. And you should be crazy to learn this. No, I want to learn, right? Then only you will be able to achieve it. Otherwise, if you go and you forget, nothing will happen. So this is definitely has a future. You can see how exactly we are able to do. We show you interlaminar, we show you the opposite side, the decompression, the same side decompression, up to the lateral canal, up to the foramen. So every pathology you can work accordingly and you have the option to treat them very effectively. So like, see, there are two kind of people. One are those are very aggressive, and those who, yeah, I'm thinking. So those who are thinking, they will keep on thinking. But now, like you plan, next 6 months I want to start. So you go here, you go here, you go here. Try to learn, and then find somebody mentor, and okay, fine, start doing the things. That is the only way to progress. Otherwise, it's not going to work. Okay, and this will give you so much of name, fame, money, everything. Like see now you do the 2, 3, 4 surgery in a day. Otherwise, it's possible to do 2, 3 spine surgery in a day with all these things. So here, this is a peace of mind, and you have the numbers. Your indications are more like those who are unfit for the anesthesia, unfit for the physician. You can take it. Even like sometimes, like even I tell you, I even now I don't have even the antiplatelet as a contraindication. Sometimes like I tell you it happens like I give you the appointment. Okay, so okay, you come and we'll do your check. Okay, doc, I'm thinking, and you are coming from 1,000 kilometers far, and now tomorrow you are here. Doc, I'm ready. Hey, you are on the ecospin, you are on the clopidogrel. So today ecospin is not a contraindication. Clopidogrel. Get the complete coagulation profile, get the FFP, put the FFP just before the surgery, do the surgery, finish. So you see the advantage. Because you see, the same patient, if he comes with the head injury, what will you do? You will wait? No. So here also, like here, I cannot say him, no, go away and come back after 1 week. He said, no, I already managed, I took the leave, I have my family, I have this one. So, because of your small cut, because you are putting a small brain, because of you are doing your percutaneously, so it's an advantage. And that is the main thing which will give you the recognition. And this is definitely a feature. And it's doable. Like you see, now you see the way we show you. So I don't think it's difficult, because for you it's the same anatomy. Like start this. So you need the good instrument, good quality instrument to perform. But if you be crazy to do this, and you see, like see, for me, this is the most exciting thing for me. I don't get more excitement than this. And when I do cervical, I'm like on top of the world. I did cervical, and patient was having myelopathy. So do what you like. Otherwise, you see, like if your job becomes your burden, then you won't enjoy. So it's a new thing, learning new thing, doing new thing. It's give you kick rather than just. Like you see, like what he needs to come here.
Hello, ya Mbak.
Because he must be having a very good set. The kids are set, the family is set, your professional life is set, something. But learning new things is going to give you the excitement, and that excitement is going to get you to the top. You will never get tired. Like you see, even if you do 5 surgery, working for the full night, you're not tired because you're enjoying. It's adrenaline going on. The moment you put the scope, then you lie down, then you sleep. But if you have one more surgery, still you will do the 6 surgery also. So follow your patient. This will give you the heights in your area. And most important, patient will be better. Like you see how many failback surgery, you see how many complications, the routine standard decompression, infection and blood transfusion and the screw loosening and process-related issues. You see, invariably, if you put the cage will break the end plate and it will go inside. And then, sorry, we can't. Cage will come out. Oh, we have to do it again. So, and see, I always tell that the screws are not required. If the screws were required, the board has already sent us with the screws. So, we are making the spine unstable and then we are putting the screws to make it stable. So we have to think about the technique which we used to do. Now we have to think, the technique we used to do according to that period of time was okay. So there was no other option. But now in the time of the technology, time, now we realize the importance of inflammation, the importance of only the fragment, not the whole piece, not put the screws. That is coming up. So that will work and it will ultimately help the society. Most important. You see, otherwise, if you have seen one patient in your family who is suffering after the surgery, like you see, then the remaining life he will stop everyone. Don't go for something. So, the impression of the spine surgery is so bad in the society that even the classically indicated patient no to spine surgery. My friend told me, never do spine surgery. So they are already delayed because of the belief. But you have the option if you have this many numbers. You see, you meet this guy. He was having the same problem and now he's fine. And we are not talking about the open. This is my endoscopy. Oh, so this way we can even convince those patients who are just afraid just because of nothing, just because of somebody else is telling something, and they are suffering. You see, most of those patients, they have everything. They have money. They can do surgery anywhere in any part of the world. But just a fear, because of the fear, they are not able to do it. So if we can make this big change, then life will be so good. They are walking. They are independent. But otherwise, you see, with the age, if you are not independent, what else your money or everything can do? Nothing. So we have the responsibility to work on this and make the people and the doctors which will have long-term good results. Thank
Hello.
you.
Yeah.